Good evening, everybody. My name is Dave Taylor from Reichert. Welcome to the webinar this evening. I've been associated with the technology we're going to discuss tonight since its inception, and we have two outstanding speakers with us tonight, Paul Karpecki and Devinder Grover. So why don't we go ahead and get started? I'm going to just introduce the technology here for a couple minutes before we turn it over to the true professionals tonight. One of the things that we want to discuss early on is the concept here about what we're measuring. You hear this term corneal hysteresis, and I just want to talk for a couple of minutes here about what that really means. So, okay, so here what you're going to see is me dropping two balls on the table, and you'll note that one ball bounces and the other ball doesn't. And I'll play that again so that you can get an appreciation for it. And the difference between those two balls is the material that they're made out of, and the one that bounces is behaving like a spring. It's returning the energy that was put into it. And the one that just kind of dies on the table there is behaving like a damper. And that is an example of a hysteresis phenomenon. The ball that kind of just died on the table was acting like a shock absorber, and it absorbed and dissipated energy. Another thing that we all deal with in our daily lives is motor vehicles, cars, and everybody knows that cars have springs to hold up the vehicle and absorb some of the bump when you go over a bump or a pothole. But what's really doing a lot of the work there is what's called the damper or the shock absorber. If you went over a bump and only had springs, the car would continue to bounce up and down. It's the damper or the shock absorber that stops that motion. And that viscous damping capacity is what we're really talking about when we talk about the term hysteresis. And here's an example of a car that has a good shock absorber on one side and a bad shock absorber on the other side. And you can see how, even though everything else is the same in this model, the bad shock absorber is allowing that wheel to really bounce up and down and cause quite an unpleasant ride for the passengers in that car. So that's just another visual example of this phenomenon we call hysteresis. So really what we're asking here when we talk about hysteresis, the hysteresis of the cornea and perhaps the hysteresis of the ocular tissue, is how good of a shock absorber is your eye? We all know we've got intraocular pressure in the anterior chamber, and we've got intracranial pressure behind the eye. And then in between, we've got the ocular pulse pounding away on these structures all day long. And there's probably other stress and strain factors involved. So the eye is a viscoelastic system that is under a constant assault from all these inputs of energy. And the question we ask is, can the eye absorb and dissipate all of that shock? And if not, what is that shock doing to the structures of the eye? And can we measure this shock absorber capability of the eye? And really, that's what the corneal hysteresis measurement is. It's a quantification of that shock absorber capability of the ocular tissue. The word hysteresis, by the way, is not a new word. It's not a new concept. This guy here, James Alfred Ewing, was a Scottish physicist that identified this phenomenon and coined the phrase in 1890. So this is something that's been with us for a long time. Hysteresis is a term that characterizes the response of applied and removal of force. So it always involves a load and unload of force, where materials or systems do not instantaneously follow the applied force, but react slowly or dissipate or absorb a portion of the applied energy, which is really what we're talking about here with corneal hysteresis. And these are some examples of things that you may experience in your daily life that have a hysteresis phenomenon. Many of you might be familiar with the Tempur-Pedic style foam mattresses, and you know from touching those and laying on those how very differently they respond from a spring mattress. And that's a great example of the type of phenomenon we're measuring here with corneal hysteresis. David Luce was the inventor of this corneal hysteresis measurement. Just passed the third anniversary of his passing a couple of days back. Dr. Luce passed away in 2017. Great guy, brilliant physicist, spent the first part of his career in the musical instrument business, and then spent the rest of his career in the ophthalmology business. He coined the term corneal hysteresis all the way back in 2001. This is a tissue property of the eye that reflects the ability of the cornea to absorb and dissipate energy. and it's specific to the ocular response analyzer, the technology that makes the measurement. It is patented, and it's an indicator of viscoelastic or viscous damping, the shock absorber effect of the eye that we've referenced a few times here this evening. And so the question I think that really makes sense to ask, and Devinder Grover, our second speaker here tonight, coined this phrase, I think, how good of a shock absorber is your eye? That phrase resonates well with his patients when he talks to them about it. I think that really is a great way to describe what we're measuring here and why it's relevant. How does this thing work? Well, we rapidly deform the cornea under a gentle air pulse, but this is not like the old NCT. Here's an image on the screen of the eye deforming under the air pulse, and I'll play that another time so you can see it again. It happens very quickly. Measurement is over in about 20 milliseconds. And what does that look like? Here's an animation of how the system works. We shine a beam of infrared light at the cornea, and we monitor the reflected light signal with a photodetector. And as the cornea bends inward under the force of the air jet, we reach an applanated state, which is detected by the maximum light intensity on the detector. The cornea then becomes slightly indented due to the increasing force of the air pulse, and then the air pulse begins to shut down, and that enables the cornea to come back to its original curvature, and what goes up must come down, so the cornea passes through a flattened state on the way back home. That gives it basically a second applanation, so you get an inward and an outward applanation during the course of one air puff, and that process takes, as I mentioned, about 20 milliseconds. This is what the measurement signal looks like. Those two peaks that you see are the in and the out applanation. Those peaks represent the maximum signal intensity of the photodetector. That's how we know the cornea was flat. And the green curve there represents the applied and removed force from the cornea. The difference between the inward applanation event and the outward applanation event is the hysteresis measurement that we've been talking about tonight. Certainly don't want to turn this into a long technical discussion, so we're going to get moving here pretty quick. The instrument also produces an IOP measurement, two of them as a matter of fact. We have what we call a corneal compensated IOP measurement, which is designed to match Goldmann on average, but is less influenced by these corneal properties that we're measuring. In the middle here, we have the corneal hysteresis measurement, which our speakers are going to describe in a lot more detail. We have a Goldmann correlated pressure measurement that is basically what a Goldmann tonometer would read now, and when the IOP-CC and the Goldmann correlated measurement differ from each other, that basically tells you that the Goldmann reading in this patient would be off, either higher or lower than what we think the true pressure is. And then at the bottom, we have what we call the waveform score, which is basically a quality indicator that lets you know if you've made a good measurement or if perhaps the patient's fixation was averted at the last second or something caused the signal to not be so good. We recommend that you take another measurement to get more reliable data. Our speakers tonight, as I mentioned, Paul Karpecki is going to be talking about the use of corneal hysteresis and IOP-CC in glaucoma diagnosis. Dr. Karpecki, most of you probably know, is a leader and a pioneer in the field of optometry. He's a noted educator and author. He's delivered over 1,000 lectures and authored over 1,000 papers related to dry eye, glaucoma, and a wide array of other topics. He is the chief clinical editor for Review of Optometry and the director of clinical content, as well as the chairman of the New Technology and Treatment Conferences. Hopefully you've been to one of those before. They're great meetings, and hopefully we can start attending them again in the not too distant future. Dr. Karpecki also serves on the board for the charitable organization Optometry Giving Sight. He got his optometry degree from Indiana University before a fellowship at Pennsylvania College of Optometry, and he's in practice with Ben Gaddy at Gaddy Eye Centers in Lexington, where he also serves as clinical director of advanced ocular surface disease at the Kentucky Eye Institute. Our second speaker tonight, Dr. Grover, is going to be talking about the role of ocular response analyzer parameters in determining risk of progression and treatment strategy. Dr. Grover is a fellowship-trained glaucoma specialist who specializes in medical and surgical management of complex glaucomas and complex cataract surgery. He's developed novel surgical techniques and works with various companies to develop and design instruments that improve surgical safety and efficiency. Authored many peer-reviewed publications, book chapters, and serves as a reviewer for most of the important peer-reviewed journals in the field of ophthalmology. and he is currently in practice at the Glaucoma Associates of Texas, where he makes his home. So I'm going to now turn it over to Dr. Karpecki. First, I need to unmute Dr. Karpecki, and then I need to turn control over to Dr. Karpecki. And if this all works, we should be up and running.
That's looking great.
Over to you.
Thank you very much, Dave. Let me go ahead and widen my screen a little bit here and see if you can see it. I want to, first of all, thank Dave for that intro because it really set the stage for what we're going to talk about today. And really this carries forward. And I'm going to focus on a few unique aspects before presenting a case and then passing it over to Dr. Grover. Where I'm going to focus on is taking the hysteresis as how important it is to understanding glaucoma, and mostly how it relates to progression of glaucoma and progression of visual field loss, and how it's protective, as he talked about from a shock absorber standpoint, when you have high hysteresis numbers. And then I'm going to show you a case that kind of ties all of that in together. We've always known biomechanics were key to this. You know, if you look at even in refractive surgery and corneal dystrophies, in fact, my first introduction to hysteresis was in patients when I was in Kansas City. I did a fellowship under Dan Dury, and we used to do a fair amount of refractive surgery, and we get patients who had these hysteresis numbers that always seemed to lead to potentially post-LASIK ectasia. And that was all we knew. We didn't have a lot. We knew it was corneal mechanism, but really the great application for me, and I think for everybody who understands glaucoma, is in glaucoma. The eye does have this mechanical structural continuum throughout it, as you see there, based on viscoelastic tissue. It's complex, interconnected, the way the fibers work in the cornea all the way to the cribriform plate. And geometric attributes are not a surrogate for tissue properties. What I mean by that is, you know, we used to think corneal thickness was such a key factor, and we would have subtraction and addition models, and all of our new research and everything has been shown, including even in the OATS, has shown that that's probably not a good descriptor, and that's not as reliable. You can't make an adjustment for IOP. We're going to go through, you know, evidence of corneal hysteresis in terms of what was just described very nicely by Dave, and then go on to the next slides of this. So let's begin with cornea and glaucoma. You know, I have to reference the OATS study first because it really put the cornea on the map. It looked at corneal thickness, and it found that, you know, it was an independent risk factor for development of glaucoma. As I just mentioned a moment ago, not as an IOP correction factor. The OATS, in fact, many of the people in the OATS group were kind of a little affected by the fact that people thought they were trying to correct that. They actually came out with a paper, which I'll show you later, that pretty much said, you know, you shouldn't use corneal thickness to adjust IOP. That was straightforward, their comments. But it really was kind of the introduction that corneal thickness had some role in this. And it was this geometric attribute to the cornea and eye. And there was a connection between that. But I think today we've come to realize there's a corneal property that much better explains all of this and the back of the eye behavior. And it's kind of tied in because at times corneal thickness can kind of give you an indication, but they are truly separate. You cannot use central corneal thickness as your indicator. In fact, in my clinic, I can't tell you how many times when I'm assessing a glaucoma patient where I have realized that corneal thickness, I mean, if it's really thin, I'll look certainly closer at patients, increased risk. But when I start seeing normal measurements or even above minimal, it doesn't really tell me a lot in terms of who's at risk or who's progression. There's one significantly superior corneal property that better exhibits that. And of course, that's hysteresis. And if you look at hysteresis, you know, I talk to colleagues about, you know, this because in my clinic, this is so critical to my decision making. And I'm going to show you a case where that played a role. And I could have pulled a number of cases out. There's about 700 publications. What's amazing is this has just been since 2005. So you think that's relatively new. I mean, in the spectrum of our understanding of glaucoma, 2005 till 2020. And yet 700 publications have come out. So in 2005, it was established as an in vivo corneal tissue property. And Dave described the grandfathers of that and how they were able to show where that were and coin the terms. Then in around 2005 to 2006, it was shown to be associated with progressive visual field loss. And that was really critical to where we are today. We're kind of fortunate, to be fair. Devinder Grover was one of the lead authors in that original seminal publication as a student who really realized and discovered that, who is of course the co-presenter today, which really gave us the basis for our understanding today. It's associated with increased optic nerve head deformation in glaucoma patients, again, that shock absorbing capabilities. Predictive of the magnitude of IOP reduction, I'm going to get into that. This one for me that really is critical is this index for predicting the worst eye, which we'll show you the study on that. But ultimately, there were further studies in 2013 all the way through to about 2017 that really showed this was a prognostic factor for the progression of many types of glaucoma. Normal tension glaucoma, independent of corneal thickness, high IOP patients that had glaucomatous-like discs but no visual field loss, and then really are true where we are today, which we're going to share with you in terms of its ability to predict glaucoma and glaucoma progression. Now, here's some basic evidence that really kind of shows us that we're dealing with something that's very stable. A lot of people, when there's variability in a measurement, whatever it might be, it leaves doctors wondering the validity of it and how much it can help. And when we see stability, we're able to utilize what's present in terms of then understanding how it correlates, meaning a person with a really low corneal hysteresis, if it were to jump around, how would we really know what that means to us? This is one of the most stable measurements when it comes to these measurements we're looking for in our management of glaucoma. It doesn't display a 24-hour rhythm, and as you see, corneal thickness does, central corneal thickness, as does IOP, which we've known for many years. It also doesn't change much with age. There's a very slight decrease in really 10 to 10.5 down to about 10.1. It's really not changing a lot, no statistically significant change over age. So you can rely on this measurement, whether the patient is 41, as in the case I'll show you in a little while, or whether they're 91. And so it really gives us that ability to have consistency, which then becomes a very important marker. There's also consistency amongst race, and I think that's also quite important. I mean, certainly there is some studies that show Indian and Middle Eastern have a slightly lower corneal hysteresis in those countries, perhaps half to 1 unit, nothing significant, but all very, very similar. So once again, what you get in this data, regardless of patient type, you don't have to adjust for it or wonder, is this as much of a factor? It really is pretty consistent amongst all races and ethnicities. But this is really the important value of why we look at this. And this is actually Devinder's study. He was involved as a student, as I said, in the time I showed this earlier, Congdon et al., and you'll see him in that American Journal of Ophthalmology in 2006. So he would have probably just been a student really at that point. The first observational study that investigated the relationship between corneal hysteresis to a variety of glaucoma parameters in the glaucoma population. They had a nice N number, 230 patients who either had primary open-angle glaucoma or were suspected of having it were included. It was defined by a reliable visual field. That means they had to show testing accuracy, as you would know, abnormal according to Oates criteria with optic nerve image photo, and all of that consistent damage then by a fellowship-trained glaucoma specialist. They looked at Goldman applanation tonometry, the ocular response analyzer, central corneal thickness, and even axial length were recorded. And then they were able to look at all of this data over 3 or more years. You got to love those studies that are longitudinal or over a time, that you can look at a lot of data and really understand it. This time, this was new. People really didn't associate what corneal hysteresis meant compared to thickness, or how to associate. What did it mean compared to glaucoma? We were trying to tie it into things. And so to have a study that had all these parameters in it, I think really made a key role in our understanding to today. It was a stepwise model, not used nor any hypothesis about interactions. It was just, hey, what can we learn? And here's the data that came out. One, it was associated with progression in this retrospective study. And if you look at the statistics, and as you all know, anything under 0.05 is statistically significant as a factor. What stands out to me from the research that Dr. Grover was leading in and played a key role in is that Goldman applanation tonometry wasn't statistical. And we see that all the time. Yes, we use it as a following patients. Yes, it's an indicator as it gets higher up. We want to be able to, it's the only thing we can technically measure today to lower. You're not going to change hysteresis. That's an extremely stable measurement. So we have to have some sort of guide to follow these patients to know what's happening. So there's a role, don't get me wrong, but you will realize as you see this that there's no statistical indication. And I've seen patients with 28 who never developed glaucoma in 30s. And I've seen, of course, patients at 14 I had to refer to our glaucoma specialist because I could not control the progression that I was seeing. So we're well aware of that in multiple ranges and patients. If you look at central corneal thickness per 100 microns, it was not a factor, no statistical correlation to progression. Years with glaucoma, baseline IOP, as we just discussed, did not. Obviously, age did. Patients over 65 would have a higher incidence of glaucoma versus those under. But notice where the red arrow is, how highly statistical corneal hysteresis is per millimeter of mercury. So really, this was the parameter most associated, number one. I mean, and that was, shocking to see the data because we were learning about this, but it's the number one parameter associated with progressive field worsening. If you take a look at this corneal hysteresis OATS study, glaucoma associated with the normal tension group. Sorry, this is the normal tension glaucoma population. This one is always a challenge for most of us. Often these end up with the glaucoma specialist. We have a great one I work with closely. And because of the fact that how could they continue to progress, and we're finally getting their pressure into target range we're hoping for. So we are needing another measurement to kind of know what's going on. These were 82 patients who were progressing with normal tension glaucoma on topical medications. As defined as a repeatable IOP of under 21, and they had glaucomatous disc damage and abnormal visual field. So these are the patients we really want to diagnose and get control of. And as they looked at this population as well, which again, a very difficult group, eyes were split into two groups, higher and lower than average corneal hysteresis. We know that about 10.5 is the average corneal hysteresis, as I showed you, regardless of race or ethnicity. That's the magic kind of number. Anything above that is protective shock absorbing, and anything below that is not protective and is bouncing off that optic nerve to make things simple. But if this is what really shows it. Of the patients that had low hysteresis numbers, 6, 7, 8, 67% of them progressed. Only a third showed no progression. If you went the other way and you looked at the 43 patients who had high corneal hysteresis, only 34% roughly of that population, 0.9%, showed no progression, meaning the 65% showed no progression with the high hysteresis, 39%, 34.9% did. So you can see a highly statistical difference that those patients with high hysteresis were protected, so to speak. Those patients with low numbers were not protected at a much greater risk, with 2/3 of them progressing. Now look at the p-values in that list. Retinal nerve fiber layer thickness had a good association. That's why OCT is so critical to this as well. Average, temporal were really key critical forms. Obviously, some talk about the Tizent slide and all that. The inferior didn't, and that's a lot of that information came from this. But look at corneal hysteresis, the most statistically significant factor you can measure related to progression in patients with normal tension glaucoma. If you look at association with visual field asymmetry, we see almost the same thing. In the AEGIS study, looking at Goldman applanation, looking at central corneal thickness, no statistical association with central corneal thickness, by the way. Drops, no association. The only one that had the highest association, again, corneal hysteresis. So you can pretty much predict by looking at those low corneal hysteresis numbers who is most likely to progress and who you need to be more aggressive with your therapy on or surgical treatments. And so central corneal hysteresis was the most discriminative index. Those who had of eyes that progressed, 80% of the eyes that progressed had lower than normal corneal hysteresis, 80%. So you only had 1 out of 5 chance of that not happening. And that's the way you would know is by looking at the hysteresis numbers and realizing they were less than average. This was actually produced by, it's a longitudinal study. I always like, as I mentioned, when you can get a longitudinal study to look at things from that long-term perspective and really understanding all the parameters. It was over 4 to 5 years. Few things that really, are critical to this. This was patients who tended to have significant IOP elevation, pseudoexfoliation patients, high tension glaucoma, and a 37-28. They had glaucoma, GLD, glaucoma-like discs. But amazingly, even with these elevated pressures and these risk factors that you see from the different forms of potential glaucoma, not a single patient was allowed to be in the study who had visual field loss. And what they were able to show, once again, in these high elevated pressures, is that the patients with the higher corneal hysteresis were in essence protected. They're the ones that were least likely to progress from non-visual field defects to visual field defects. And so that was a great, so whether it's a normal tension, our normal pressure range we might range, and any of the high tension patients, our number one predictor is higher corneal hysteresis is protective, lower, less shock absorption capabilities, more damage to the optic nerve, more chance of glaucoma progression. If you look at this, this is predictive of conversion to glaucoma. So this I think is extremely important. This was our 4 to 5 year longitudinal study I referred to. If you look at the role of corneal hysteresis as a risk factor for the development of glaucoma, over these 4 to 5 years, 54 of the 287 eyes, which is about 20%, developed repeatable visual field defects during a 4-year follow-up. So this was the probability of developing glaucoma over 4 to 5 years. And look at how the breakdown is incredibly telling to me. As you look at the lower than average corneal hysteresis, you can see how quickly and how much more they progress statistically. They have a higher than 10.5 corneal hysteresis, or 10.2 in this number. You can see that they were the ones that were most protected, and you don't see that conversion to glaucoma. And it was independent of corneal thickness, independent of their IOP at the time, independent of age when you adjusted for all those other factors. And of course, you know, everybody talks about, what if I lowered, you know, some of these new drugs only lower pressure by 1 millimeter, or a surgery that may lower, like the Hydrus has, you know, added benefits from 1 to 2 millimeters. And they say, well, that doesn't seem like not a lot. It is a lot over years, 4 to 5 year time frame. Each 1 millimeter mercury lower corneal hysteresis is also a real factor. It was associated with an increase of 21% risk. So not only is IOP important, but so is corneal hysteresis. And that's the way you need to be thinking about this. If you were to take a patient who had a corneal hysteresis of 10.2 versus a patient who had 9.2, 1 millimeter mercury lower, or going the other way around, raising it by 1, they would have an increase of 21% of more likely to develop glaucoma during a follow-up visit. So by lowering, they're 21% more protected. By raising hysteresis by 1 unit, you increase the risk by 21%. This is also an important measurement I want to touch on, because when I show you a case, I kind of have to have a little bit of a definition of it. If you look at IOP-CC, this is corneal compensated. This is predictive of conversion as well to glaucoma. And again, this takes into account corneal hysteresis, and it's often very similar to Goldmann applanation tonometry. But on occasion, you will see differences. It's the pressure measurement provided on the ocular response analyzer and is less affected by corneal properties, meaning the Goldmann applanation tonometer is affected by corneal thickness. If you were to take a patient who had LASIK and do pressures before their surgery and then decide to do IOP after, you would find a difference. That's not going to happen with IOP-CC because it's not related to thickness. It takes into account the exact measurement and then the hysteresis to understand the whole properties that are placed from a biomechanical perspective. So it has no correlation to central corneal thickness. This is also really important. You know, years ago, we used to have these presentations that would talk about subtracting 5 millimeters based on, you know, a very thick cornea over 600 microns, and it was under 500, you had to add IOP. Well, the factors have come out since then. If you look at some of this data, there's very little correlation. In fact, 50% chance you would have not just of missing the IOP, but actually of adjusting in the wrong direction, meaning it should have gone down when you made it go up. Anything in that yellow are the areas or the zones where it was not predictive. It was not associated, or you were able to predict the corneal thickness affected the IOP. It was only at those few little dots out in the extremes where you were able to say, yes, at that level of thickness or that level of thinness, we can associate the change in the IOP. So adding or subtracting is gone. And we're going to also understand that really corneal thickness isn't our true measurement, is not correlated in the normal tension, not correlated in glaucoma, primary open angle, or the high tension. It was corneal hysteresis all along. Very thin corneas tended to measure low IOP, and very thick, but look at all the stuff in the middle. Did not correlate, and 50% of the time it was the other way around. The reason I put this in, and this is the Oates study group. These are the people that, you know, created the publication we all rely on and look back to. And for some reason, you know, after Oates, people started subtracting and adding based on corneal thickness. And the Oates group had actually come out with a publication, as you see here, it said, don't do that. You should not be subtracting or correcting IOP because it's not accurate in terms of what you're going to get. And in fact, as I just showed you, 50% of the time you'll move it in the wrong direction. So it is a superior indicator of IOP. You can see that Goldmann applanation tonometry is affected by corneal thickness. As I mentioned, if you did pressure before and after a PRK or LASIK, you would see a difference because of thickness. No association, therefore, with IOP-CC. That remains consistent regardless of the corneal thickness. It is a much superior indicator. And you get that. When you're looking at your aura, you get corneal hysteresis, which I've talked about being so valuable. But you also get IOP-CC, which I think is extremely critical for us to be able to understand that. So the TARP chart is actual Goldmann affected by corneal thickness, central corneal thickness. And then the IOP-CC is designed to read like a Goldmann if corneal thickness had not affected it, to be a proper reading, essentially, of what we're getting. And again, this is what I referred to earlier. You know, you'll notice that if you had a series of patients who'd had LASIK, the pressure pre-LASIK is always going to be higher. And look at the difference, about over 4 millimeters of mercury, because Goldmann doesn't account, the corneal thickness affects it. Whereas if you looked at hysteresis, you would see that statistically it's the same, and it should be the same. The patient didn't all of a sudden, you know, develop a different IOP in their eye. It really was just a structural change, not an accurate change. So this becomes critical. That's why IOP-CC is so valuable as you're getting your measurements. This is a 3-year study, a Felipe Madero study, that also kind of showed the same thing, that the IOP-CC was more associated with actual glaucoma progression than was Goldmann or any other rebound tonometer or anything else you can measure. IOP-CC had the strongest association with visual field loss versus any other way to measure. As you can see there, 27.4%. So really, of course, people are saying, well, of course, that ties into hysteresis. Well, that's true, and that is our best predictor. But I also want to know what the actual IOP is and really how that plays a role. Let me give you an example. Let's stratify the risk, and you're gonna have to participate in this one. I'm gonna give you a poll question that asks what you would do. So all of this group, this patient I'm gonna show you, tell me your thoughts, what you would technically do based on the limited information I'm gonna give you. 41-year-old African-American female was referred into my clinic for a second opinion. The doctor felt like he definitely wanted to put this patient on medications, but she was a little resistant to starting a medication at age 41 that she would have to be on for, quote, the rest of her life. Initial examination, this was just a case in February, a couple years back. Now, I think what always worries us, positive family history. She said her mother had glaucoma and been on drops for as long as she could remember. She's obviously not on any ocular therapies, doesn't have any ocular surface issues, no systemic medications, no systemic diseases that are present. So we take a look at her optic nerves, and you can see they're, you know, significant. They're large nerves slightly. You know, you can see definitely somewhere around that 0.7 CD, maybe 0.6 on one side, 6.5, 7. Vision, of course, is unaffected. Now, this is the interesting thing. The referring doctor's notes recorded Goldmann pressures that are in the 20s, and that's where I went into the exam thinking, all right, we've got some 23s. That's a little high on that side. I like to get at least 3 to 4 IOP measurements as I'm deciding what to do with these patients. And I will tell you, my IOP measurements at KEI were consistently, and I did try and see the patient at different times, so it was somewhat of a diurnal throughout the day changes, but it was always 18, 19, 18, 19, maybe 117 in there. I never had a 20. Pupils were normal, no afferent pupillary defect, and we have the new Kai kinetics, didn't show any changes at this point. Slit lamp was normal, no apparent pathology. Angles were 4, mild pigment at best in the angles. So you have a family history. You have pressures recorded at one point, maybe being as high as 23, certainly consistently in the high teens. And you've got fairly significant CD there, maybe even some cupping as you look at that. I mean, really questionable to that level in a 41-year-old with a family history. So we run visual fields, and I always like to get a couple visual fields too, and this is one good reason. You can see our reliability isn't really high on this first visual field, but you're not seeing any major changes. When we did any structural or functional type effects that are occurring, and really no significant depression. When I repeated the visual field, it was a little bit better, I guess a little practice, but again, no pathology, no sort of signs, I should say, related to visual field loss in this 41-year-old patient. But now OCT, you know, has me kind of looking at this closely. The OCT images are pretty similar to what our optic nerve looks like, maybe even showing more, about a 0.75 in that left eye, 0.69, 0.7 CD in the right eye. We've got pretty good retinal nerve fiber layer, about 97 microns, and it's pretty consistent between the two. Perhaps, we look at retinal nerve fiber layer quadrants as all being kind of in the green or fairly good thickness. But I'm still kind of concerned as I look at the optic nerve and all that we've put together. And so the question comes to you as we pull up, this POL factor. You've got race factor, positive family history, suspect nerves with CDs around 0.7, 0.75, possibly elevated IOP into the 20s, although I never was able to get a reading of that, even on what we're measuring at that time, Goldman. So let me ask you, what would you do with this patient?
And everybody should see the poll right now, and you can vote by clicking the radio button next to what you would do with this patient. We'll just have a little fun with this, and then Dr. Karpecki is going to show some additional data, and we'll do the poll again. Still getting audience responses here, Dr. Karpecki.
Excellent.
It's running really high right now. 80% would say continue to monitor without treatment, and then the second highest is diagnosed with glaucoma and begin treatment at 14%, and 6% saying refer to a glaucoma specialist. So that's,
wow.
I don't think that's going to change too much. I'm going to close the poll at this time, and then you should be able to show your next slide.
Fantastic. Does this change anything? Although, to be fair, this is a pretty sharp group. I mean, I looked at this patient's eyes. I looked at where we're at. I really felt a lot more confident, though. I mean, this was referred in. The doctor wanted to start medications, really wanted what to do. But, for me, this is my comfort factor. This is home cooking here when I can get a corneal hysteresis of 12 above average, tied in with the suspect case, not overly showing any significant issues, but family history, potential, all of that above 10.2, 10.5 really helps me feel good about doing exactly what this very sharp group of attendees knew to do. I got to give them credit. They didn't even have this information. Interestingly enough, the IOPCC is lower by quite a bit. 19 versus 15.5 maybe. Good reliability on the signal, so I could feel good about this measurement. And so I did well, let me ask you again, although this group was pretty darn good. I mean, they kind of hit the number right away.
100% now say monitor without treatment, so that's
beautiful.
Pretty strong.
The interesting thing about this, a year later, you guys were right, and so many of you were right at the beginning with very little information other than the OCT, the visual field, and a little bit of the history. One of the things really important is when you're discussing family history, especially when they're close to their mother or father, I ask them if they really lost vision, would they go blind? It may just be another, her mother might have had ocular hypertension, just like, she may have had if she was truly 23 at one point, but never developed glaucoma. And she was able to say that, yeah, my mother did not go blind, never mentioned losing vision, but had been on drops, her whole life and still is. No change in optic nerve head evaluation, no disc hemorrhages in the course of the whole year. These are at least 4 exams, maybe even 5, because I do a few extra at the beginning to just gauge the target IOPs. Always consistent, 18, 19, or ocular response analyzer, IOP-CC, I love that measurement, consistently 15. That explains perhaps why nothing's happening. Corneal histine, of course, that never changes at 12, and her OCT remains stable. In fact, at 2 years out now, got to see her here in February. I'll just show you the more sensitive because all the rest of the OCT is pretty much identical. But even 2 years out now, look at her average retinal nerve fiber layer thickness, 97 at the beginning, it's 96, 95 today. And so we made the right call. This is really, the histories has made me feel better about it, so did the IOPCC, but this really felt a lot better to be able to monitor this patient confidently.
Great case, excellent presentation. I'm watching to see here if anybody has raised their hand, but apparently you've made things so crystal clear we don't have any questions. So I'm gonna change presenter over to Dr. Grover. Hopefully he is all teed up and ready to go, and switch it over to him. Thanks, Dr. Karpecki.
My pleasure.
Nice. Okay. Excellent. Well, there aren't too many people in the world that I know based on with hysteresis that know more about hysteresis than Dave Taylor. So he's a tremendous resource. and very accessible, and has been involved with this finding for such a long time. So, Dave, thank you for organizing this, and Dr. Kopecky, you did a phenomenal job, really setting the stage and giving a nice thorough overview of the current literature. I'm going to, review just a little bit of that, just brief, because Paul did such a good job, and I'll be able to go into some cases of glaucoma progression. So these are my disclosures. I am a consultant and speaker for Reichert, and but these are my own slides, my own thoughts, and my own opinions. All right, and thoughts on masks. My childhood hero, the man in black, who predicted that he would say that we'd all be wearing masks in the future. The other benefit of COVID-19, despite the devastation it's caused worldwide, is it's giving us all a chance to kind of try to laugh through some of these situations and come up with some other fun memes. And I'm sure some of us have been maybe enjoying a couple alcoholic beverages every now and then to kind of put things in perspective. My personal disclosure, we talked about my financial disclosures, but I have personal disclosures. And, in truth, before OATS and before corneal hysteresis, my view of the cornea was that it was really just this unimportant window that would allow me to see important things like the optic nerve. So we'll see if that changed. So I'm going to just, Paul did such a great job doing a review of really some of the most powerful studies. So I'm going to not spend too much time on that, and then I'll switch straight over to some clinical examples in my practice where I thought this was hysteresis was such a powerful component in my decision-making process. Paul pointed this study out. This is one of the first studies that showed two things. One, he got things a little bit wrong. I wasn't the lead in this. I was just a clueless medical student that really didn't know anything about hysteresis, but could get my name on a paper. But thankfully, that's changed. But he got everything. He summarized the rest pretty well, and it truly was one of the first paper to demonstrate that corneal hysteresis was associated. This was a retrospective study, but it demonstrated that corneal hysteresis was associated with visual field progression, more powerful than age, corneal thickness, and IOP. Now, the only other thing about the IOP, and this is what you need to kind of focus on whenever you look at any other any studies on progression of visual field. When you control for something, it falls out of the analysis. So whenever we do studies on progression, these are patients with glaucoma being followed by a glaucoma specialist usually. And so you're ideally being controlled, and the pressures are being controlled. So IOP usually falls out of the analysis because it's being controlled, the IOP is being treated, it's being altered. Now, if it would be unethical to follow patients with untreated IOP and see them progress, and then IOP would become a statistically significant factor. But in a lot of these studies, and even the ones I'm going to talk about next, the reason why IOP falls out of the analysis usually is because it's being treated and it's being controlled. And so you're altering that variable, and it's no longer a significant variable. But Paul did a great job. Felipe Medeiros he was initially at UC San Diego, now he's at Duke, really did he should receive a lot of credit for the work he put in to this DIGS cohort, this diagnostic innovations in glaucoma study, because he was really the first person to do these powerful, well-designed prospective studies following patients over time, and he kind of was the first to show in a prospective manner that hysteresis was a predictor for glaucoma progression. And this slide I really like because we all have patients in our practice that despite everything we do, you see this. I don't think I have my pointer. Wow, we're having all kinds of. Oh, there we go. Can you see it? Okay, good. These are patients that were stratified above or below hysteresis of 10, and as Dr. Kopecky pointed out, patients with a low hysteresis are at increased risk of getting glaucoma and getting worse with glaucoma, whereas patients with a high hysteresis are at a lower risk. And what's powerful here is look at the patients with a higher than average hysteresis. None of them, these lines this is all based on visual field progression and visual field index. You don't see any of these rapid progressors in that above 10 hysteresis group. But look at these patients. These are people that are being followed by a prospective controlled study by Felipe Medeiros and his team of specialists And despite everything, they're being followed over 5 years, and you have people tanking. Their visual fields are just tanking. Not everybody, thankfully, but you have these people rapidly progressing. You don't see that when the hysteresis is above 10. And this, Paul pointed out that initially after Oates, we had these correction factors, and that kind of has fallen by the wayside based on the Oates leaders. But this is really, I think, what people hoped those algorithms and those nomograms would do, is when you look at it with hysteresis and pressure by hysteresis, a patient with a hysteresis of 11, above average, a good shock absorbing eye, one that's at a low risk of getting glaucoma and progressing from glaucoma. If they have a pressure of 20, 22, they have a very low risk of getting glaucoma and progressing from glaucoma. But when you look at patients that had a hysteresis of 7 and a pressure of 20, they had a much greater risk of progressing from glaucoma. So this really shows that algorithm that we always wanted and that we always wished we had, and it really kind of shows how powerful knowing hysteresis is when you're taking care of patients with glaucoma or that are suspicious for glaucoma. And so as Paul pointed out, this study showed that hysteresis was 2 times more predictive than visual field progression and 2 times more predictive of visual field progression than Goldmann appennation, and 3 times more than corneal thickness. And it was one of the first studies to show in a prospective way that hysteresis is an important factor to consider when assessing glaucoma progression. And he followed up this, as Paul has already shown, with glaucoma development, showing quite powerfully that patients with a low hysteresis were 3 times greater risk of developing glaucoma over the follow-up period. Now, Nate Radcliffe and his group, when he was at Cornell, I believe, did this study, which was really also powerful and provocative. Makes you think about other possible components or mechanisms of actions with prostaglandins. And what he showed was that patients that had a low corneal hysteresis tended to actually have a better response to prostaglandin analogs than patients with a higher hysteresis. Now, this is just an observational study showing an association, not causation, so I caution you on kind of drawing too much into this. But again, it shows, I think what it does point to is how powerful hysteresis is when it comes to giving us insight into patients with glaucoma and their risk of progression, risk of development, and their likelihood of response to medications. Dr. Kopecky did a great job kind of summarizing this IOP-CC measurement, this corneal compensated IOP. Goldmann appennation is still our holy grail. It's still our what we consider the gold standard for following patients, but it's flawed in so many ways, and we all know that. Anybody that uses Goldmann appennation realizes that it's flawed. But what's powerful about IOP-CC is I think it is much more powerful than Goldmann appennation and not flawed in the ways that Goldmann appennation is. And I'll show some examples of that. And then Felipe's group now, he's at Duke, continued with the study, and Paul also showed this study as well, thankfully, showing that the IOP-CC, this output by the Aura machine, the hysteresis machine, was more predictive of rates of visual field progression than Goldmann appennation or rebound tonometry. So it's really, I think it's a very powerful measure or output from hysteresis, from the Aura machine, and I'll show some examples of how powerful it is. So this is actually courtesy of Felipe in the DIGS cohort where he was following, again, a patient followed by a glaucoma specialist over 4 years, and you see them getting a progressive, you can see here, a progressive loss of nerve fiber layer on OCT and a progressive subtle corresponding visual field defect. Despite the fact that the patient had a thicker than average cornea, their hysteresis was much lower than average, which would have identified them and already put them in a high risk category and possibly would have predicted this progression before it occurred. Again, this is someone who's being followed by a glaucoma specialist and being theoretically controlled, still progressing right before our eyes. So, when I first got this technology, this is one of the very first patients that I used it on because it was so, this patient just had me so confused. And in truth, this patient, I would say the finding of this patient and with using the hysteresis pretty much rocked my world as far as what I thought I understood about glaucoma and how I was trained to treat patients and take care of my and treat glaucoma. So this was a young female of Indian descent with no significant past medical history. She had an extensive neuro-ophthalmology workup, and she had thin corneas. Pressures were 10. She's on no medications. She's not hypotensive or anything like that. She's on no meds. And these were her optic nerves when she presented. In the right eye, you can see this beautiful playing out of the nerve fiber layer. And then here on the in the left eye, you see this classic inferior notch and this wedge defect of the nerve fiber layer, focal loss of the nerve fiber layer. Pathognomonic for glaucoma, and I would say almost pathognomonic for low tension glaucoma. But you see this fault coming through on OCT. You see the loss of the inferior temporal nerve fiber layer on the left eye. This is her right visual field from 2015. This is her left visual field, and this is from 2006 when she was actually still in India, in Chennai. And then in my office, you see that classic paracentral or central scotoma back in 2015 in that left eye, corresponding to specifically that area of nerve fiber layer loss that we see on exam. So here we go. So my patients that I think fall in this low tension glaucoma group, based on the LOGITS, the low tension glaucoma study, demonstrated that there was a suggestion that brimonidine had a possible IOP independent effect that was shown to be better in patients with low tension glaucoma. So I typically use brimonidine as my first go-to in patients with low tension glaucoma. But what did this patient look like? So her right eye pre-treatment, focus on this column right here. In the right eye, her Goldmann applanation is 10. Her IOPCC, that output by the corneal hysteresis machine, the aura, shows a pressure of 15, and her hysteresis in her right eye is 9.7. Now look at her left eye though. Her Goldmann applanation is 11, still amazing, presumably. Her IOPCC is 16.7, but her hysteresis is lower. So, you know, you can see an asymmetry in patients in eyes on the hysteresis. It's not it's usually very similar, but sometimes you see this dramatic asymmetry. We don't understand why. So I put the patient on brimonidine in her left eye twice a day. She comes back 4 to 6 weeks later, and in her right eye, the untreated eye, her Goldmann applanation doesn't change, her IOPCC doesn't change, and her hysteresis doesn't change. She comes back in her left eye, and her Goldmann applanation is still 10. She went from 11 to 10 on brimonidine twice a day. In every glaucoma drug study known to man, well, actually not known to man, but approved by the FDA in the United States at least, this would be a non-responder to brimonidine. But look what her IOPCC did. Her IOPCC went from 16.7 down to 11.4. And you have some natural fluctuations in the hysteresis. It didn't really significantly change. But what's crazy is this is someone who I would have presumed to be a non-responder. She somehow responded to brimonidine based on the IOPCC measurement. And the aura doesn't record anybody's data. So it doesn't know that this patient, there's no way that aura could have known that this patient's eye was treated with anything. It just took another measurement 4 to 6 weeks later, and it demonstrated that the IOPCC decreased, even though Goldmann applanation did not catch it and missed it. And the common theme from all this is that what I think is actually very true is that Goldmann applanation, when corneal hysteresis is average or above average, Goldmann applanation is pretty good. But I see the largest discrepancy in patients that have a low hysteresis. In my patients that have a low hysteresis, almost invariably, and you'll see this trend, Goldmann is wrong and it misses it and it underestimates it. And that's how you get these patients that are progressing and getting worse at a pressure of 11, and everybody's thinking, oh, what's going on? We got to get the pressure even lower to 8.25 or 7.99. But that's not it. What it is that Goldmann is actually missing it. And in these situations, IOPCC, I think, is a much more powerful reflection of the true intraocular pressure. So let's look at another case. So this was still a young Hispanic male, 59 years old, had a disc hemorrhage noted by his optometrist, sent for evaluation. and he's mildly myopic, average corneal thicknesses. His pressures are 13 and 14, and he has this resolving disc heme in his right eye. Now, whenever I take care of patients that are of Latin descent, I'd always think back to the LAL study, the Los Angeles Latino Eye Study. And what's powerful about the LAL study that I don't think is focused on a lot is the average untreated IOP, Goldman IOP, the average untreated Goldman IOP in a newly diagnosed patient that was considered Latin American in Los Angeles when the study was being done, untreated average IOP was 17. So don't be fooled and falsely reassured by some patients that come in with a pressure of 17 and that you think have glaucoma. Use your clinical judgment to make that call. Don't focus so much on the numbers. Look at the optic nerve and use your clinical judgment, because that's the average of 17. So if there's an average of 17, there were some patients that presented with 35, with 25, but there were also patients that presented untreated with 13 or 14 because the average had to be brought up to 17. Here's the hysteresis back in June of 16, and this is what the standard output is. You have the IOP-CC, the corneal compensated IOP, you have the corneal hysteresis, the IOP-G, which is what the machine thinks the Goldman applanation should read. Of all the measurements, this is the one I put the least weight on. And then the waveform, and that waveform should be around 7, 8, or 9, just like with everything we do. If you have a poor quality study, you have poor quality information. But this patient has a hysteresis of lower than 10, so that he's already in a higher risk category. It's actually significantly lower than 10. You know, I would say 9.5 puts you in a high risk category. If you're in the 8s, that's actually pretty significant based on that one curve that I showed before. And the same thing is true with his left eye. Pressures of IOP-CC is 17, even though my Goldman affinations were measuring 13, 14. So here is optic nerves. You can see that disc hemorrhage, I think it was resolving. It was right about here. But without question, glaucomatous optic nerves bilaterally. Again, on OCT, especially on the right side, you see that focal loss of nerve fiber layers, specifically on the right inferior border. And again, in the right eye, you can see an early nasal step corresponding to the nerve fiber layer loss. And so this is what I did. I started him on latanoprost on June 1st, 2016. He came back on August 1st, 2016. His pressures went from 13 and 14 to 13 and 12. Again, every study on prostaglandins done since they've been around, this patient would be considered a non-responder. And you know, people would say, oh, put him on a branded prostaglandin, put him on Lumigan, put him on Travatan Z, he'll be a better responder. And this is, again, challenged everything I thought I knew about glaucoma. Because in this patient, his IOP-CC, when I treated him with latanoprost, went from 16 to 12 and from 17 to 12, even though he did not change at all through Goldman applanation. Just throwing off everything that I think I know about glaucoma and glaucoma monitoring and patients that respond to drugs. That's for some reason, and again, I see this classically in patients with a low hysteresis. There's this discrepancy between Goldman and IOP-CC, and it can be dangerous in patients with a low hysteresis. So here's a patient that we followed with low IOP. One of my partner's patients that I saw one time. 79-year-old woman, no significant past medical history, or he's been following her for several years, actually since 2014. You can see a screenshot of this is the biggest range I could show on my EMR. That over the past 2 or 3 years, her pressures have always, every time we've seen her, have always been 12, 10, 11, 12, 14, something in the low range. And the AEGIS study showed that if you could get a patient in the low teens, under 14, you could essentially stop visual field progression. And that's our goal for these patients with advanced glaucoma. Her optic nerves were 0.9. She was on this fixed combination of brimonidine and timolol. She had a history of ECP in the past when she underwent phaco. And here are her visual fields. You can see significantly constricted visual field in the right eye, with central loss of vision in the left eye as well. We don't like this. We don't like seeing this at all. This level of loss is very, very impactful and detrimental to a patient's quality of life. And what I also don't like is this. Here's a patient being followed by an amazing glaucoma specialist, probably one of the, I would consider one of the top glaucoma specialists in the country. And over the past, 10 years, she has, before our eyes, slowly gotten worse. Which, usually when you treat glaucoma appropriately, when glaucoma is treated appropriately, I would say we win 95% of the time. We should not see this. This is not a foregone conclusion that a patient gets worse. This is a patient, I think, that has not been adequately controlled. Thankfully, her left visual field hasn't really significantly changed, but you can see the left one's already pretty much cupped out. She's already in that floor. But in the right, she went from 2012, and she literally progressed in the right eye over 5 years with progressive loss of nerve fiber layer. So if you want to see advanced glaucoma, here are two examples of advanced glaucoma, unfortunately. Very classic advanced glaucomatous optic neuropathy. So so here's what we did. Put her on she's pressures of 12 on this brimonidine timolol combination. I added latanoprost, followed up a month later, and her Goldmann pressures were still 12 and 11. So what do? You switch her to a branded prostaglandin. You can add a rho kinase inhibitor. You can start this 79-year-old on an oral medication, Diamox, metazolamide. You jump to surgery and create a new drain, or you continue to observe. So, Dave, you want to try the poll?
All right, that poll should be up right now. What would you do with this patient? Go ahead and vote. Responses are coming in. It's pretty evenly split right now, bouncing around a little bit. A lot of people saying proceed to surgery. That seems to be the leading choice right now. And then the second closest is increased medical therapy. So that's what we're getting, 45% proceed to surgery, 30% increased medical therapy. I'll close the poll, Devinder, and you can tell us what you did.
All right. I don't really know. No kidding. Yeah, let's see what I did. So here we go. Okay. So it's a little awkward on the slides. Sorry about that, but let me get my pointer. I don't have my pointer. There we go. Okay. Yeah, that's weird. I don't know my pointer. Okay. So I added latanoprost, followed up in a month, and her Goldmann appellation hasn't changed. So I get a hysteresis on her. And her IOPCC is 17 in the right. Her IOPCC is 19.3 in the left. And her hysteresis are in the low 8s. So what did I do? I put her on latanoprost, right? I kept her on latanoprost. Oh, did I mess this up?
No, don't think so. So now we know, based on what you just showed there, we've got some really low hysteresis, and was it that the IOPCC was substantially higher than you thought?
Yeah.
And so now, does that change anybody's opinion? We are already leaning towards, the audience is already leaning towards either increasing medical therapy or proceeding to surgery in this patient. So what did you do, Devinder? Was it the meds, or did you do surgery?
So what I did was I was able to, there we go. There's my pointer. Okay, so yeah, so I put on latanoprost, right? And I repeated the hysteresis measurement. And like I said, her Goldmann appellation didn't change, but her IOPCC went from 17 to 13 and from 19 to 14. So she was a responder to prostaglandins. I just missed it. And I couldn't see it because Goldmann missed it. So now I'm following this lady, and both her Goldmann appellation is 12 and 11, and her IOPCCs are no longer 17 and 19, but they're 13 and 14. And so, given the fact that she has extremely low corneal hysteresis, she's someone that I will follow more closely. I will have a low threshold for surgery, but she's on, 2 bottles, the combination medication twice a day and the latanoprost at night. we'll follow her more closely. But if I can get a 79-year-old in the low teens through every measurement that I trust, hysteresis and IOPCC and Goldman appellation, I have a low. I'd have a hard time convincing myself to operate on this patient. These are the people who classically, you talk to the old school glaucoma docs that don't understand and appreciate hysteresis. They're the people that would say, well, she needs a trab, and I need to get her down to. I do my trabs, and I get a 7.85, and that's where she needs. And you expose these patients to these dangerous trabeculectomies, where they're at extremely high risk of this hypotony maculopathy, because you get a patient down with a Goldman of 7. I bet you her IOPCC will be, probably 7 or 8, maybe 9, but that's unnecessary because you can actually keep her controlled. You were just following her in this situation with a high pressure. You just didn't realize it. So, my thoughts to wrap all this stuff up, as we're going on a little bit longer than we planned to, sorry about that, is that, I think corneal thickness really put the cornea on the map, but I think corneal hysteresis is a much more powerful indicator for glaucoma progression and development of glaucoma, and I think it's just a more sophisticated and powerful tool to evaluate the shock absorbing ability of the eye. And all the studies that that have been done in a prospective manner have shown that hysteresis is an independent risk factor, independent of corneal thickness, independent of IOP, of glaucoma development and progression. And I think it's thinking of the eye as this biomechanical continuum, not just what's happening in the front of the eye with the cornea, but how is the optic nerve actually responding and being affected by the pressure. And that's really what the powerful thing is. And that's one thing I never really understood by Goldman appellation is I don't care what's going on in the front of the eye. What I care is what's happening in the optic nerve. And I think corneal hysteresis gives us a sense into how the whole eye as a spectrum behaves when it's exposed to the stress of pressure. And I think the biggest other take-home point I'd like you guys to leave with, and girls, is that when hysteresis is low, you're going to see the greatest discrepancy between IOPCC and Goldman appellation. So I would consider corneal hysteresis to be a glaucoma vital sign. I do not make any clinical decision in my glaucoma patients or my glaucoma suspects without knowing the hysteresis. I walk into the room and I feel naked. I feel like I walk in the room and not knowing their pressure or not knowing their optic nerve health. I feel like I will not be able to make an adequate and informed decision about a patient's clinical state unless I know their hysteresis. And I'm much more likely to operate on a patient with uncontrolled glaucoma and low hysteresis than a patient with uncontrolled glaucoma and a high hysteresis. I still don't think the cornea is that important, but I think the biomechanics of the entire globe are. So this is one of my favorite pictures. I took this at the slit lamp. The other role of the cornea is it allows me to see myself in its reflection. So I guess it does have a role. So it's just some random advice. I think we're all kind of, the whole country and the whole world is going through some craziness, and I hope you all are staying safe. It's so important to get outside and get some fresh air. Make sure you continue to take care of yourselves and your family and your colleagues in addition to your patients. And I think a lot of us have, young families and young kids, and despite all the stress of everything we're going through, I really don't think there's ever going to be a time, hopefully in our lives, where we're going to have this much time to spend with our families and our children, especially those with young kids. And it's such a unique opportunity to think about that. And we're trying to hang on every moment that we are kind of in a lower, not as busy right now. And the other thing is, you can't stop laughing. You gotta, even in moments of stress and moments of sadness and moments of fear, I think human nature, at least my human nature, is just to kind of continue to try to laugh. We're getting some fresh air, and sometimes we just pull our tables out and go sit outside and enjoy. There actually has been some discussion, all joking aside, and some concern about, the use of these non-contact tonometers, especially hysteresis, and the Aura machine with this puff test and aerosolizing these viral particles, and is that a risk for ourselves, our staff, and our patients? And so I do think that now that we all have COVID on the mind, I think it's something that we should discuss, and it's something that is a real and valid concern, because you do need to make sure you're keeping yourself safe, keeping your patients safe, keeping your staff safe. So, what do we know of COVID right now? There's really a lot of things we know are coming out of China, and are published in some very powerful journals. And these are patients in different regions of China, not out of Wuhan actually, but in different regions and different hospitals in China. And these are patients with known confirmed COVID. Somehow they have the ability to test broadly, even though we still don't. And what they did in that first study, the first study at the top, of the 30 patients that they had in their study, they took tear and conjunctival secretions from the patient, all patients, and did PCRs on them. And only one of those 30 patients that had known COVID, that were hospitalized with known COVID, actually where they would isolate the virus particles. In the Wu study, of the 38 patients in this study, they were only able to isolate the actual virus via PCR in 2 patients, so 2 out of 38. And in the Zhang study, they had 102 patients with suspected COVID that were admitted and had the classic symptoms and signs, and were, by all intents and means, had the coronavirus, but they only were able to confirm the diagnosis of COVID-19 in 72 of these patients. And of all the patients that they looked at, there was only one of those 72, or you can say one of those 102, that actually had PCR positive results by isolating the virus in their tear film. This is something that's just came out, not out of China, out of Singapore. Singapore has been one of the leaders in managing these pandemics. They really were at the forefront of approaching this in an intellectual and scientific-based manner to manage all this stuff. And they learned the vast majority of this based on the SARS epidemic, and really learned a lot, and are not being reactionary but being proactive. And in their study, they took 64 tear samples from the 17 COVID patients they had, and they took repeated samples out from day 3 to day 20 when their initial symptoms appeared, and they were not actually able to isolate any viral particles at all in their tear films. So again, these studies are showing that, can you find it in patients? Sure, rarely you can find it, but I think it's extremely rare. And these studies confirm that. Multiple studies from different centers are showing that it's extremely rare to isolate the coronavirus from patients that have known diagnosed COVID. Now, I'm not an expert on COVID, but this is the cure. Sorry, I still laugh when I see that. I think these non-contact tonometers, specifically the Aura, which is not just a non-contact tonometer, but it's actually giving you multiple very powerful and useful information, can be considered in other ways probably even safer in this time in checking pressure and monitoring patients and properly risk stratifying them, when you really want to be able to kind of get a sense in this time to minimize the patient's interaction with the healthcare system, knowing who needs to be seen right now during all this COVID pandemic craziness, and who can be followed less frequently. So if a patient has a corneohysteresis of 13, I'm much more comfortable saying, hey, you know what, Ms. Jones, stay at home. I'll see you in 6 months. But if a patient has a hysteresis of 8, I'm going to say, sir, you know what, you are pretty high risk. I need to see you, and I think it justifies the risk of you coming into the office for me to evaluate you, because you are in such a high risk category. The machines can be easily wiped down and sterilized, and the staff is behind it. They're pretty much protected. The air puff, there's a study by Britt that showed that you can aerosolize material through these non-contact air puff tonometries. This was done in the 90s. While that is true, the air puff that was done in this study was one of the old classic puff machines. And that puff was about 4 to 6 times more powerful than what the Aura machine has. So I think I actually feel quite comfortable using the hysteresis machine, the Aura, and feeling that it's better taking care of my patients, also in a safe way, and it's non-contact. So you're actually, I would say, maybe even decreases your exposure. But there's so much we still don't know. We're just trying to get the most up-to-date information as it comes. But even when you look at there's a JAMA article of patients that were diagnosed with COVID positive symptoms or COVID-19, they were COVID-19 positive in Wuhan. There's a JAMA article that talks about all their symptoms. Only 20% of them actually had a viral conjunctivitis or conjunctival injection. These are people that were known diagnosed. This COVID, this coronavirus, is not the badness of this virus is not that it is this virulent, tough, nasty thing that's so scary. The reason why it's so bad is the asymptomatic transmission that's aerosolized through the mouth and through coughing. It's that patients can have it and be contagious through their mouth, not through their eyes, for 10 to 12 days without having any symptoms. And that's why COVID is so dangerous. It's not because, it's so resilient. It's very easily denatured and destroyed by just sun and by a very weak alcohol solution. So you don't need to, Hep C is much more tough and much more scary in my mind. Hep C can stay viable for 2 weeks on a surface, whereas COVID, if it's just exposed to some unfavorable environments, it gets denatured immediately.
On that subject, touching on that, Devinder, I've had a number of docs, Paul Singh and others, in the past couple of weeks telling me that they are now relying on Aura in their practice more. They don't want their technicians doing Goldman anymore, being 6 inches away from patients' faces. So they're doing the Aura exclusively in some practices now because of this.
Yeah, I think that's a great point. I mean, the technician can easily be 2 to 3 feet away from the patient while they're doing it. They have long arms. During all this times of stress and emotion, I think it is also very important for us to take a step back and just be thankful. Count our blessings for what we have. We're so very fortunate right now. Be thankful for your family, your spouses, your kids, your friends, your colleagues. Be thankful that we're able to have these kind of exchanges. And still be able to interact in different methods during all this craziness. I have 2 young kids, and every night at dinner we sit down and we go around and we do what we call our rose, our dud, and our bud. Our rose is what we loved about today. Our bud is what we hope happens tomorrow, and our dud is what we didn't like about today. But the other thing we do is we just tell each other that what we're thankful for. And then we do our best to make each other laugh. And I tell my wife how thankful I am to have someone that I enjoyed being quarantined with, and she was like, "Wow, that must be nice." Anyway, thank you guys for your time. It's been great to work with Paul on this, and Dave, thank you for coordinating this. I'm sure Paul and I would be happy to take any questions that you all may have.
Perfect segue, Devinder. Thank you for that awesome presentation. I'm going to switch back to showing my screen here. Hopefully you guys can see that now. And we did get a number of questions that have come in during the course of the presentation, most of them through text, so I'll read through a couple of those right now. And Dr. Karpecki, you're now unmuted, so whoever wants to answer the question can. The first one was related to use of the Aura with COVID, and I think we've just adequately answered that one. The second question here is, when you reduce the IOP, does it cause an increase in the hysteresis, or does it change the hysteresis?
Yeah, and I can certainly take that one. That was great, by the way. I enjoyed your presentation, your style, excellent, and just conveyed a lot of good information. Yeah, so the good thing about hysteresis is consistency. Really, no significant changes typically as you alter the IOP. So look at it more as kind of that, as Devinder described, Grover said, more of your risk factor. I'd want to know if it was a low one to begin with, and you're not going to see statistically, it's not going to go from 8 and then you lower the pressure to your 11 and it jumps up to 10, meaning it's protective. It really is the shock absorbing capabilities that exist for that eye, and that, you know, stays consistent for the patient. You're able to kind of realize where they're at, and that you have to be more aggressive in getting their pressure down when it's low hysteresis.
I'll make one comment on that because there is one study in the literature that talks about an increase in hysteresis after IOP lowering. And this was a case study on a patient who had a TRAB, and the IOP changed by 20 millimeters or something like that. In those instances, certainly the hysteresis will move around, and it's actually more a function of the way the machine operates. It's a bit technical, but we don't apply as much air pressure to a patient with an IOP of 50 because we'd have to really wallop it hard in order to indent that cornea to the same magnitude we would of somebody with a pressure of 10. So that study's kind of irrelevant because it's such an odd situation. But as you stated, Dr. Karpecki, in routine clinical practice, I don't think you're going to see big shifts in hysteresis as a function of treatment. Another question we got is, when do you find it useful to do Goldmann tonometry if you have an aura? Doctor says, I find it saves me time having the technicians do aura, and there's little resistance from patients compared to the old puff tonometers.
Yeah, I can respond to that. That's a really a very insightful question, and you know, the Goldmann applanation has been around for what, 70, 80, 90 years now, and it is still considered by most of my colleagues to be the gold standard. Every study we've ever done in glaucoma, all these landmark trials that we look at, Oates, Sigits, Aegis, TVT, PTVT, every landmark trial that we know that has informed our decision making about glaucoma is based on Goldmann applanation. So, you know, it is going to be extremely hard to just remove that from the picture when managing patients with glaucoma. I think I don't think it needs to be a mutually exclusive thing. I don't think it needs to be, hey, we'll do hysteresis and you can't do Goldmann, or you do Goldmann, you can't do hysteresis. I think there's a couple things. One, I think it's useful to have both pieces of information. Two, for patient flow, you know, if depending on the number of patients you're seeing, if you're seeing a large number of patients, it's just for patient flow, it's hard to get every patient to get a hysteresis measurement every single visit. Unless you have 3 or 4 or 5 machines, and Dave Taylor would love that. And you could do that. But what I do in my practice is I still feel like it's important to know what Goldmann is. I think it's extremely important to know what the hysteresis is. And I still put a lot of weight in the IOP-CC. But as Dr. Karpecki and Dave also said, you know, outside of patients that are extremely uncontrolled when the pressure is extremely high, you do a significant change in the pressure, the hysteresis doesn't change significantly. In my patients where I know there's that dramatic, some of the cases I showed where there's a dramatic discrepancy between IOP-CC and Goldmann applanation, I get hysteresis measurements on them every visit because I want to know their IOP-CC. But in my patients where I don't see that large discrepancy with Goldmann and IOP-CC, because I know their hysteresis is about, you know, average or above average, then I can improve my patient flow by because I have a Goldmann applanator in every exam lane. But there are, I know, some optometry practices as well as some comprehensive ophthalmology practices, and I think it would be very justifiable if you're seeing, if you know, the average you know, optometry and comprehensive ophthalmology practice probably sees, if they're getting a cross section of this country, sees 5 to 10% of their patients are glaucoma patients or glaucoma suspects. In that situation, I think it would actually be very reasonable to have a couple aura machines. You don't, and people have approached me with that question and said, hey, then I don't need to buy fluorescein, I don't need to buy applanator tips, I don't need to worry about decontamination. And I think it would be extremely reasonable in a comprehensive practice to depend solely on the aura for hysteresis and IOP-CC. But in a glaucoma practice, it's hard to just to not do it. And like I said, it doesn't have to be mutually exclusive. You can do both. And why not get the most information? That's how we learn. That's how you make these observations that in certain patients there's a discrepancy. And some patients just don't get a reliable hysteresis measurement, and their waveform is off, and you need other ways of measuring their pressure. So it's not mutually exclusive, and I still think it's important to have all the information you can when making these clinical decisions.
A couple rapid fire questions here. We're running pretty long, but the audience is hanging tight. Still most of the people on the line here, so there's a few more questions we'll try and bang through quickly. One person asks if there's any information on reliability for patients with small apertures.
I don't think there's evidence, but I mean there's practical evidence. I can't point you to a study.
Me neither.
But I don't think it would be. I don't know. Dave probably knows this, but I would refer to Dave. But if you'll see the waveform, and if I wouldn't necessarily attribute it to the aperture of the fissures, as opposed to just the patient's ability to keep their eye open and allow the machine to take a reliable measurement.
Basically, the instrument will measure almost anything you put in front of it. Very few patients that you can't get a measurement on. If you do have lid squeezers and things like that, just like with Goldmann tonometry, there is enough room to hold the lid open. We do recommend using a cotton swab or something like that, and there's plenty of room to reach in there and hold the lid up if you need to on certain patients, but it generally isn't a problem. Another question, what do you record in the chart? Do you document all 3 or 4 measurements? Do you record IOP-CC, hysteresis, Goldmann, and waveform score?
Well, I'll jump on this one first as well. So I don't typically record the waveform. I just want to know that it's accurate. You know, just like if I'm doing an OCT, there's ice. You know, if I get a 9 out of 10, 10 out of 10, I'm fine with it. But I don't record that as long as I'm able to look at it and know that the data and information is valid. But I think on the first exam, I absolutely have to have the corneal hysteresis. I too feel like I'm missing some sort of data. Like Dr. Grover said, if I don't have that, I don't feel confident going into the lane and knowing what to do, especially in those patients where they're kind of in between, or even in cases where I do know it's glaucoma, but just I'm worried about the progression risk. I need to have it. So hysteresis is critical, and then I record Goldmann and IOP-CC. As Devinder said, I think all 3 of those are really valuable as you put them together and able to look at it, and then you have good information for monitoring the patient long term. After you've had that first measurement of hysteresis, you may not need that one in future measurements unless, as he mentioned and others, Dave did too, unless there's a significant IOP rise, like lowering as in a TRAB or some sort of a procedure that could warrant that. But for most glaucoma drops, it's not going to shift or change too much enough to need it. I just use the IOP-CC and the Goldmann going forward.
So we have another question here about IOP-CC. Oh, this is an easy one. Is IOP-CC measured with the same device as hysteresis? Yep, IOP-CC, hysteresis are both measured simultaneously during the same measurement process with the ocular response analyzer. Another question that just came in said, do you use IOP-CC when setting target IOP? Like the Canadian system for target IOPs, and would you use IOP-CC instead of Goldmann for your target IOP?
Yes, I do. I mean, I think the IOP-CC, I don't see it as a different, it's what I think is it's just a measurement that's the true reflection of the patient's pressure. And so my target pressure is not a Goldmann target, it's not an IOP-CC target, it's just a target. I know that based on studies that that I want, you know, if I see a patient progressing in a certain number, I want them lower. And I use this specifically in my patients with advanced glaucoma and with a low hysteresis. Those ones I'm much more concerned about. But no, I set a target based on, you know, the patient's exam and the pressures at which they're progressing, and I use that target. And usually, you know, don't take from this presentation that that IOP-CC and Goldmann are always off and always different from each other. The vast majority of times they're actually quite similar. What's different is that when it matters, they're usually off. So when the hysteresis is low, and the patient's in a higher risk, that's when it's off. And so those are the patients that need extra care anyway. But no, I set a target pressure, and then in those patients with the low hysteresis, I don't think the Goldman pressure is 10 is that target. I think a Goldman pressure of 10 in a patient with the low hysteresis is an inaccurate measurement, not that their pressure is truly 10.
That's a good. Mm-hmm.
Topical medications have been shown to affect hysteresis. Has this research only been done on prostaglandins? That's a good question. As far as I'm aware, keeping an eye on the literature, I've only seen studies on prostaglandins. I don't know if you gentlemen have seen anything else.
That's all I've seen as well. And then, of course, what Dr. Grover presented really nicely about, the hysteresis was somewhat predictive. An observational study in terms of the amount of IOP lowering, but that was also a prostaglandin study, if I'm not mistaken.
There was a mention of a correlation between hysteresis and ectasia. I think you brought that up, Dr. Karpecki. Is this something useful for a pre-LASIK predictor of risk?
It actually is. I mean, if you look at patients that have a low hysteresis number and you've got, and you're thinking of doing LASIK and they're a relatively high myopia, you might want to look at an ICL procedure. I definitely think that there's a correlation there. Now, of course, the huge value of this technology is in glaucoma. I mean, that's really what I couldn't manage glaucoma patients to the extent I do without it. I just, as we talked about, that's where my great value is. But to say there isn't application in refractive surgery wouldn't be fair. There truly is, and it has that risk, especially when you've got numbers like, let's say, a 6 or a 7. And you have a patient coming in, and their PACs maybe are 530, but they're a minus 6 and they're minus 5. You're wondering, well, should I treat them? Should I thin them? Surprisingly, those are some of the patients that are prone to ectasia post LASIK, and so you may lean towards a PRK, and if it's greater than that, you might lean to a lens-based procedure. So there is value. That's just kind of a side benefit, I guess, of Aura. Getting hysteresis, not the primary usage, but there's value there.
Actually kind of ties in a little bit to another question. Someone asked if we could explain the graph a little bit, and that's related to the ectasia story just a little bit. We actually spent a long time focusing on hysteresis and Aura parameters as a refractive surgery, a decision-making aid, and there definitely is some utility of the hysteresis measurement in predicting ectasia, as Dr. Karpecki mentioned. But what we learned, and there's a lot of publications on this, is that signal that you get from the instrument is actually full of information, and the shape of those peaks are really related to corneal biomechanics as well. And what you'll see in your keratoconus patients and your post-LASIK and ectasia patients is those peaks tend to be lower in amplitude, and they tend to be a lot noisier. They're very jagged. So if you want to use this device in refractive surgery decision making, there are some PowerPoint slides and some publications that can really teach you more about interpreting these measurement signals that are quite helpful in refractive surgery decision making. We have another question about riboflavin treatment and does it affect it. I think that's related to corneal cross-linking. Real early on in the Aura story, I went over to Dr. Seiler's facility and we measured porcine eyes, and we looked at whether or not the hysteresis changed pre and post cross-linking. And the interesting thing is that it does change in animals. We've seen this in rabbit studies, we've seen this in pig eye studies, but in live human keratoconus subjects that have cross-linking performed, the hysteresis does not change. And that's not, we don't understand that in detail, whether that means cross-linking doesn't technically. Remember, hysteresis is an indication of the viscous damping properties of the cornea. Cross-linking is supposed to change the elastic or stiffness characteristics of the cornea. So it could well be that cross-linking is changing something in the cornea that is not well characterized by the hysteresis measurement.
Yeah, and on that note, Dave, I think the other thing that's important to point out is kind of what I was mentioning in my talk is, when it comes to glaucoma management, we don't really care what's happening to the cornea of the front of the eye. What matters is what's happening to the back of the eye, the optic nerve, the lamina cribrosa, and how the optic nerve and the entire wall of the eye responds to the stress or the pressure. Mm-hmm. And cross-linking will change the structure of the cornea, but it does not change the structure of the sclera or the optic nerve. So I wouldn't expect, it may throw off the measurement, but I would not expect it to change the physical properties of the part of the eye that matters.
And that's a perfect segue into another question somebody asked related to using hysteresis in post LASIK patients. And your comment there, Dr. Grover, is spot on. When the cornea has been modified, you can no longer consider that to be a surrogate for back of the eye behavior. Just like you wouldn't take a post LASIK patient and say, well, you've got a thin cornea, therefore you're at risk for glaucoma. Post LASIK patient is going to have lower corneal hysteresis than average, and you can't look at that low corneal hysteresis and say this means that there's something funky about your eye wall, and I think you're at risk for glaucoma. So anytime you have a patient where you know that that cornea has had a surgery or a biomechanical modification of some type, or has keratoconus or something like that, I wouldn't consider the hysteresis to be very useful as a glaucoma risk factor, but the IOP-CC measurement should give you a better indication of the true pressure in those eyes. And the last question we have here then is related to something new called CATS. I don't know if most folks even know about it yet, the correcting applanation tonometer surface, which has just come out on the market in the past number of months, which is a replacement for the traditional Goldman tip, and is supposed to make an IOP-CC-like measurement. And there's 7 studies in the literature that show that it actually does effectively compensate for corneal biomechanics. I don't know, Dr. Karpecki and Dr. Grover, if either of you have clinical experience with that device yet to answer whether or not how this correlates with the IOP-CC measurement from the aura.
I got it basically about a month ago, one week after our big national meeting, and after the COVID pandemic just hit, and I have them in my office, and we have 4, and we basically have stopped doing applanation given everything. So the literature is without question extremely powerful out there, and that shows that I think it is a much more powerful reflector of the true pressure than old-fashioned Goldman applanation, but we haven't had the chance to play with it yet given this global pandemic.
What I'll say is that in theory, those 2 measurements should correlate well based on what I've seen in the literature, but the data is not there yet. We have somebody that says, oh, Princess Bride is one of our favorite movies, mine too. Great that you put that in there, Devinder.
Mine, I agree. Love
Great.
it.
It's all right that we're all showing our age here, gentlemen. Final question here. Actually, they're just still coming in, and I'm really thankful for everybody staying on. We've gone way past our scheduled time, but there's still the vast majority of the audience still on the webinar. So must be that people are quarantined and have nothing better to do. Somebody says, how is the measurement affected by dry eye? Do you guys have any clinical experience? I know of a couple publications on that.
Clinically, I see a lot of dry eye. I mean, a big part of my patients, a lot of the glaucoma patients are sent over for that on the cornea side. You know, I still do on all of them, you know, aura measurements of glaucoma. I mean, I'd look at the waveform to make sure that it was consistent. And if it was consistent, I'm not really clinically aware of significant changes that have stood out in that patient population. I mean, I know there is high potential with the topical medications, prostaglandin analogs to develop dry eye and ocular surface disease. And so the question is, would that change hysteresis measurements? And I'm not aware of seeing that clinically myself. I'd love to hear what the data says, Dave.
You know, there was a study from Brazil many years ago where they held patients' eyelids open with a lid speculum for 2 to 4 minutes and then did repeat measurements, which is very painful if you've ever tried it. And what they showed was that you get some degradation in the quality of the measurement signal, which can cause increased variability. But that is a cruel and unusual experiment that is not, I think, anything like what you would see even in a normal, you know, dry eye clinic with the vast majority of your patients.
Yeah, I agree. I would say the only thing I've ever seen extreme dry eye patients do is just have a poor waveform.
Mm-hmm. Yep, me too.
Finally, here we have in a multi-physician practice, how is it possible to measure all patients on the aura without having multiple auras? I think you touched on this, Dr. Grover, from a practical standpoint, especially if you see the same patient perhaps at different offices.
Yeah, you know, we have one in every location. And what we found to do was, you can't do it on, like you said, you can't do it on every patient at every time. So I tie it to something. I have a standing rule that I'll see a new patient, and it's nice to do the aura measurement before you put any drop in the eye. And you really should not be ordering tests until you've actually seen a patient. Most insurance companies don't like that. So I will not get a hysteresis until I've seen a patient. Typically, if I see a new patient, I will have them, if they're pretty low risk and everything else is pretty reassuring, I will have them get a hysteresis measurement on their next follow-up visit. If I see a new patient and I think I'm going to start a drop or change the system in some way, then I will go ahead and, even though they've been dilated or something, or I've done gonioscopy already, I will get a hysteresis measurement. But I pretty much have a standing order that I get a measurement of the hysteresis about once a year, every other year. And so every patient of mine that comes in, I do a photograph of the optic nerve once a year, once every other year, something like that. And so my staff has basically, they've tied it to that. So anytime any patient, any established patient gets a photograph of the optic nerve, they get a hysteresis done. So that's the standing thing. All my new patients get a hysteresis done on their second visit. If I don't add a medication, I get a hysteresis every time I change the system. Anytime I add a medication or do a therapy, I get a hysteresis before and afterwards, because there can be some subtle change in that due to medications. And then I also get a hysteresis in every patient where I see there's a great discrepancy between Goldmann and IOP-CC. So, you know, I think if you have a large, busy practice, you may want to have more than one machine, because logistically, just getting patients up there and tested, it takes, you know, even a very efficient technician can probably do it all in a matter of 2 to 5 minutes, depending on the mobility of the patient. But it's not realistic to get it on everybody and every visit unless you have more than one machine.
Yeah, and just to add to that, now obviously that was a great answer, because especially in the case like Dr. Grover, where he certainly is glaucoma specialist. Now, you know, you have a general optometric or general ophthalmology practice where you're seeing, you know, quite a variety of patients that are coming in, and I think you, or even when I'm in cornea, you know, I have a day and just dedicated to that. I kind of like the cornea still, believe it or not, even after this presentation. But I will just, my staff know that anybody who has an elevated pressure, anybody who's glaucoma suspect or glaucoma patient, or I think we have, you know, what other criteria there? I have to have an aura measurement, and they just know to do that. And then all the other patients, they just do, you know, screening pressure measurement, you know, such as a robotic one, whatever kind of quick kind of measurement. And only then, if I see something different, will I maybe send them back for it. And that way, in that general clinic, you know, it's only being used in maybe 1 out of every 4 or 5 patients, and allows for streamlined information, valuable, and I get away with 1. But if you're at a glaucoma practice or seeing a lot more high volume, then yeah, you're going to find the utility of this technology is so valuable. You have to have it. You have to find a way to make it flow.
Okay, and I think with that, we will call it a night. Thanks everybody for staying on well past the scheduled time, and really appreciate everybody taking a break from quarantining to be with us this evening. This session was recorded, and we will probably post it on our YouTube channel. We will send out a follow-up email to everybody that's been on the call to let you know where that video is, and probably give you some other information related to getting a demo of an instrument or purchasing an instrument if you're interested in that sort of thing. Also, here are the presenters' emails. If you haven't noticed, on your control panel, there are some downloads, a couple of magazine articles that you can download, and also a slide that's got the presenters' email addresses in case you want to contact us with any follow-up questions. And these questions are all recorded that have come in via text. So if there's anything that we didn't get to, we'll try and weed through all those questions and respond to people via email with answers to the questions. I want to thank Dr. Karpecki and Dr. Grover for spending time with us this evening and sharing their knowledge and their experience. It's certainly been an honor, and we really appreciate you taking the time to do that. I want to thank all of the attendees that stayed on with us for so long, and hope that you are all doing very well, you and your families, and really look forward to seeing you at a trade show when this is all behind us. Thanks, everybody. Have a good evening.
Thank
Excellent.
you.
Thanks, Dave. Thanks, Paul.
Thank you, Devner.
Good night, guys.
Great. Good night. Thank you, guys.